Why don't we start? Vicky Cook, who is an allergist, a pediatric allergist out of Victoria. And she really has spearheaded and really championed virtual health, especially in the allergy context. And I think has really helped me learn that allergy and allergy testing and allergy education for our patients is totally feasible in our small rural populations and very worthwhile, especially. So in the last several years, even outside of my training, a lot has happened in allergy, and I think we all will find this super interesting, not only for our patients, but our own kids. So I will let Vicky take it away with her presentation. What I'm wondering is if you guys can put your questions into the general chat box or to me directly. I'll read them out at the end and have Vicky answer them. Okay.
All right. Oh, thank you, Zanetta, for that very kind introduction. So I wanted to go through today some of the prevention and treatment for food allergy in infants, because as you mentioned, there's been lots of changes over the last 5 to 10 years with how we do this, and we have now many more options in our toolkit compared to previous, so where we used to tell people to just like avoid the food, carry your EpiPen, and we'll see you in 5 years and hope you outgrow it. That's no longer our approach, and there's so many things we can do to, number one, like reduce the rates of food allergy in our patients, but also to identify them early and treat them when they happen. So, there we go. So these are my disclosures. So namely funding for my fellowship project, which is a website, and then some speaking fees with ALK, Aralez, Bausch, and Sanofi. None of these are relevant to food allergy or what I'm discussing. So our main learning objectives today, so number one is we want to be able to counsel parents regarding early introduction of the allergen, appreciate why we can offer the treatments that we now have. So when we think about adverse reactions to food, right, the word allergy gets thrown around an awful lot, but allergy essentially is specifically an adverse reaction to something that is mediated by your immune system. So basically your immune system has labeled something incorrectly, right? There's lots of bad reactions to food. Some people get, diarrhea and belly pain with milk. That's lactose intolerance, not an allergy, different thing. And then there's things like caffeine, right, where it makes your heart really race. You might feel jittery. Again, not an allergy. That's sort of an expected toxic effect of a food. Allergy is really that immune-mediated adverse reaction to a food. And really that's part of, so our immune system has a lot of jobs, but mainly its job is to go around and to try and determine what's me, like what's self, what's not self. And then of the things that are not self, it has to determine what's a threat and what's not a threat. And that's really your immune system's job and what it spends all the time doing. And allergy is really just this problem, this failure of your immune system to distinguish between a threat and not a threat, right? So allergy is when your immune system sort of inappropriately recognizes something in our environment the same way it would a dangerous threat. So in many cases, a parasite actually, right? So the cat dander is not actually going to hurt you. The grass pollen also not going to hurt you. The peanut shouldn't hurt you, but sometimes our immune system gets a bit confused. It labels them wrong, and the result is allergy. There's different kinds of food allergy, right? So there's our immediate onset, hives, swelling, problems breathing, vomiting, fainting. That's sort of usually within minutes, but occasionally up to 1 to 2 hours. So that's our IgE-mediated food allergy. And then there's some of these sort of delayed kinds of food allergies, things like eosinophilic esophagitis, and then things that we're familiar with, sort of the cow's milk protein allergy, the food protein-induced proctocolitis, so the mucus and blood in our poop when we're babies, and then the really impressive vomiting, delayed vomiting that we can get, so food protein-induced enterocolitis. The one that I'm going to spend the most time talking about today is IgE-mediated food allergy. So this is our immediate EpiPen-needing, life-threatening kind of food allergy. So IgE-mediated allergy happens when our immune system sees a food protein and it accidentally labels it the same way it would a parasite. And so we generate what are called IgE antibodies, which then hang out on our mast cells. And then when we next see the food, we eat it, our body is like, that's a parasite. And our mast cells go off, and we might get hives and swelling and problems breathing and vomiting and fainting and sneezing and all of those things. And this is the same mechanism as, so those of you, so we're getting into sort of the pollen season. So anyone with pollen allergies right now might be experiencing, itchy eyes, sneezing, snot production, right, when you're going outside. And that's the same thing. So that's when your immune system has accidentally labeled the pollen protein the same way it would a parasite. You breathe it in, and your body is like, this is bad, and we make snot, and we sneeze it out. Your body is trying to get rid of a dangerous threat. So I guess the important thing to recognize is, well, why is our immune system labeling these things wrong? Like, our immune system is supposed to be so clever, and it is, right? Like, your immune system is so smart, but it really relies heavily on context. And so where we meet a protein strongly influences what our immune system thinks it is. So there's a lot of things that come into play as far as like our susceptibility to allergy. So who gets an allergy? And it starts with some underlying genetics. And then it's not just the genes though. It's also an impact of where we live in our microbiome, right? So if we live in a city, in a developed country, our microbiome is very different than if we live in a more rural area or in a developing country. And having the right set of genes develop these skin barriers. At the top on the right, we have keratosis pilaris. So those are those little bumps that sometimes show up on our cheeks or on our arms. 30 to 40% of the population, very common. That's just, we have this tendency towards dry skin. We make too many dead skin cells, and those plug up our hair follicles, and then we get these bumps. There's eczema, keratosis vulgaris, and so that's when the people have lots of lines on their palm, have just overall dry skin that's a little bit, that actually predisposes us to allergy is a skin barrier problem. In susceptibility to these skin barrier defects, all are they code for glue that holds the skin together. So what happens, so in someone with eczema or keratosis pilaris or ichthyosis vulgaris, we're missing some of the glue that holds the skin together. And so instead of having a lovely concrete wall as a skin barrier, instead what we wind up with is a bit more like a chain link fence, right? So our skin barrier is supposed to be a concrete wall, but for a lot of us, like it's a huge proportion of the population, like 30 to 40% of us, instead our skin barrier, even in areas of skin that look smooth and healthy, when we go and we look at them under the microscope, there's lots of little holes there. And that means water can get out, the skin is just generally a wee bit more dry, but also it means that stuff can be seen when it shouldn't be, right? So if you've got a concrete wall and the cat dander lands on your skin, like the little immune cells that lie under your skin, they're never going to hear about it, right? They're not going to care, they're never going to know. But if you have a chain link fence and you have lots of little holes in your skin barrier, then when the pollen protein or the cat dander or the peanut protein lands on your skin, then you've got these little immune cells that line your skin. Their job, right, is to look for invaders. Like that's why they're there, right? You get a cut, parasites getting in, those little immune cells, they're going to see it, they're going to raise the alarm. But what happens in eczema and keratosis pilaris, like where we've got a chain link fence, the stuff lands on our skin, the little immune cells see it, and they're like, oh my God, guys, we found an invader. If you see this thing again, make sure you get rid of it. And that is how allergies happen, right? So if you meet the thing through the skin, then we're likely to label it as an invader. And so you guys have probably heard about the dual allergen exposure hypothesis, which is basically saying context matters. So if you have a leaky skin barrier, so that's anyone who's got keratosis pilaris, ichthyosis, eczema, bad seborrheic dermatitis in infancy is also a hint towards this. So these are all these underlying skin types that tell us that we've got a leaky skin barrier. We have a chain link fence and not a concrete wall. And so when there are things in our environment landing on the skin, our little immune cells are going to see them and they may label them like a parasite, essentially, right? Because they think they're trying to get in. Conversely, our gut also is lined with tons of immune cells, but the immune cells that line your gut, their job is a little bit different, right? So they're looking for things like food and good bacteria, like that's their job. So when you're eating things, the little immune cells in your gut pick it up and then they say, hey, everyone, chill out. This is a food. Don't react to this. Everything is fine. So if you meet it through the skin, then the little immune cells there send out all of these invader cytokines. They send these messages to the immune system to label things as an invader. But if you're meeting something through the gut, so if you're eating a food and you're meeting the food in your intestines, instead the little immune cells there send out these like chill out, calm down cytokines to tell everyone that it's a food. So we always want to meet things through the gut instead of through the skin. And what I always think is so interesting is often, patients tell us, oh, I've got asthma, or I've got seasonal allergies, or I've got food allergies. And all of these disorders look very different, but they're actually all the same problem. So the problem all comes down to that skin barrier that is not intact, that predisposes us to make labeling errors. So if you have eczema or one of those other skin barrier problems, then you are much more likely to have food allergies, to develop asthma, and to develop environmental allergies, and that's the allergic march. So understanding that and saying like, okay, well, the reason we develop food allergies is if we've got this sort of skin barrier problem and we're meeting the foods through our skin instead of through our gut, that's why we're labeling things wrong. Then we know that there's a few things that we can do to prevent food allergy then. So the key aspects of trying to prevent a food allergy are by taking advantage of those little immune cells that line our intestines, right? So as soon as we can, we want to get the food going through the intestines so that we can train the immune system that a food is a food and not a deadly parasite. And then the other thing that we can try and do is keep our skin barrier as healthy as possible. So especially if we have a tendency towards eczema, we want to be doing things like avoiding soap, right? Soap strips our natural oils. We want to keep all of our natural oils, and then we want to add moisturizer on top of our natural oils. And if that doesn't cut it, then that's when we want to be using our medicated topicals. And while it's not totally the focus of what I'm talking about today, eczema is not caused by food. So it's always interesting, people say, what am I eating that's causing my eczema? But it's totally the other way around. The skin barrier problem comes first, and then that's what gives us problems with foods. So having eczema is the thing that places us at risk for the life-threatening food allergies. So introducing allergenic solids, and I don't know, so anyone who's been practicing for a while, I'm sure has a bit of whiplash from the channel, because back in the year 2000, everyone recommended, like, your infant wasn't allowed to eat anything, do not eat anything, wait for years. And then now we're telling you the opposite. We're like, quick, as soon as they're like barely sitting, quick, feed them the peanut, give them the almonds, right? Eat everything. So we've gone from saying you're not allowed to eat anything to like eat everything immediately, in not a terribly long period of time. So back in the year 2000, based solely on expert recommendation and not on any evidence, there was a blanket recommendation to delay introduction of foods for kids who were considered at high risk for food allergy, and that was essentially anyone who had a first-degree relative with eczema or seasonal allergies or asthma. And so they said, don't introduce any solids until you're 6 months, no milk until you're a year, no egg until you're 2 years. I have no idea where they got these numbers. And then no peanuts, nuts, fish, like no anything else until you're 3. So that was the recommendation. And then, a few years later, people were starting to say, gee, allergy rates they're really skyrocketing. Like the rates of allergy are sure going up. I wonder why. And then some clever people made the observation that, there was a similar genetic population. There's children living in Israel. And then there were these children with a similar genetic background living in the UK. And the kids in Israel had like no peanut allergy, but the kids in the UK whose genetic background was very similar had all of the peanut allergy. And they said, wow, what's going on with that? And then when they looked at the infant feeding practices, what they found was that the kids in Israel were actually eating peanut very early. So one of their first finger foods were these peanut puffs called bamba. And they're like cheesies, but they're peanut. Really good. And so that's all of these kids, when they were starting really young, getting their first solids in, peanuts were being eaten. And so I said, gee, that's really interesting. And as I mentioned, so the year, if you look at the gray line in this graph, so for kids who are less than 5 years of age, at the year 2000, sort of the prevalence of food allergy is sitting somewhere around that 3% for all age groups similarly. After the year 2000, particularly in that infant or like preschool age group, so the less than 5, you see the rates of food allergy go up fairly sharply prior to this study. And so this is some of that influence of our recommendations to avoid everything, which was clearly not great. And then there's this interesting study that observed that, gee, when we start the peanut early, we're not having as many problems. So based on that study, then we did a quick about face and said, maybe we shouldn't delay anything after 6 months. Maybe you should go ahead and feed it. And in 2013, the Canadian Pediatrics Society, we followed suit and said, yeah, quick, maybe just start eating the things. Maybe that's better. And then in 2015, this really important trial came out. And this is so the lead author on this is the same gentleman who published the paper about the differences in infant feeding practices and the rates of peanut allergy. So they went ahead, after that observation, they went ahead and actually studied this in a really large prospective trial, and they compared early introduction of peanuts, somewhere between 4 and 11 months, depending on developmental readiness, versus waiting until you were like 5 years old to eat the peanut. And what they did, in terms of the intervention, they had these children eating peanuts most days of the week, so in total like 6 grams of peanut protein per week, until they were 5 years of age. And the results were really impressive. So in the people that followed the protocol, there was like no peanut allergy, right? So 0.3% peanut allergy if you actually did the regular peanut ingestion, compared to like a 17% rate. And even in people like with the intention to treat analysis, so people who weren't following the directions so well, the difference was still very impressive. So this dramatic reduction in peanut allergy with early introduction. And this has subsequently been shown with a variety of foods, not just peanut. This principle applies. And so this takes us to sort of now our so recently updated in 2020. So what do we say with the Canadian Pediatric Society statement? So our current recommendations are particularly for infants who are considered to be at high risk of food allergy. And so that's any infant who has any personal history of atopic disease. So that's eczema, other diagnosed food allergy, allergic rhinitis, asthma. In infants, it's like 99% of the time it's going to be eczema that you're going to see, and then or a first degree relative with any atopic disease. And so again, eczema, allergic rhinitis, asthma, food allergy. So in those kids, we want to see introduction of the common allergenic solids at 4 to 6 months based on developmental readiness. If there's no obvious risk factors, then introduction at 6 months is appropriate, and we always still want to support breastfeeding. And once we introduce the foods, we should be offering them at least a few times each week to maintain tolerance. So what we're really trying to do, remember, is we want those little immune cells in the gut to be seeing that food, to be sending out those sort of calm down, chill out cytokines so that our immune system is learning that the food is a food. And then if we identify any reactions when we're trying things, then we want to refer. So early food introduction, this is sort of like a how-to. So one thing I think that's really important to keep in mind, because there's often a huge amount of anxiety surrounding food introduction, right? So with some families, we see a lot of people who might be hesitant to try the common allergenic solids because they're fearful about a reaction. So I think one thing that's really important to tell your patients is that the risk of a severe allergic reaction on like the first time you're eating a food is extremely low. And we have huge population-based studies to back this up, right? So in particular, so there's really large Australian data sets where they have really good uptake of the early introduction of the allergenic solids, and the rate of reaction on initial exposure was 2%. And almost all of those were skin reactions, and none of them were severe or life-threatening reactions. So that's a really impressive take-home point for your patients, is that when you're introducing the allergenic solids, like you have a 98% chance of nothing happening, which is great, right? So I think from a take-home standpoint and a reassurance standpoint, this is a very safe thing to do, and it's a safe thing to do in the home environment. And ultimately, it's better to do it. It's in fact safer the sooner you do it. So the longer you delay, like especially, right, if you're nervous, right, parents think like, I'm too nervous, I want to keep them safe by not doing it. And as the allergist listening to that, I'm like, we're putting them at risk by not doing it. So like our perception about what is safe and what is not safe is not necessarily the same. For me, the not safe thing is holding off on doing that. Now with each day that goes by, we are increasing our risk of having a reaction. So we're less likely to have a reaction the sooner we do it. So I guess the next thing is sort of like which foods should we be introducing? And I will, I actually didn't put them in this, but I'll send along some links to be passed out at the end of this, just with good resources for this. So HealthLink BC has a reducing allergies in your infant statement, and Food Allergy Canada also has a statement called Eat Early, Eat Often, which outlines these as well. But there's the top 10 food allergens, which is actually a lot more than 10 because the tree nuts are not all the same. They are all different things and need to be introduced separately. But we're thinking our dairy, our egg, peanut, tree nuts, wheat, fish, shellfish, soy, and sesame are sort of the common. There's other ones that are a bit less common, but we still see, like things like mustard is on the list. I don't push people to introduce mustard early, honestly. But there are some emerging allergens. It was just part of a study that looked at some of like unusual and emerging allergens, and in particular, other legumes are becoming more common. And you might think of things like the Beyond Meat burgers, like also Cliff bars, like any of the protein bars that have all of like really high concentrations, a lot of the time, of legume-based proteins. So pea is becoming more common, lentil and chickpea we're seeing a lot of, more than we did in the past. In terms of forms of the food, so the big thing we want to be mindful of is age and choking hazards. So we always want it to be a form of the food that, number one, will not cause choking, right? Whole peanuts and whole nuts should not be given to kids under 4. People should be sitting down when they're eating them. Those are high choking risk, and we do not want to cause aspiration while we are preventing our food allergies. So things that are useful are like butters and nut milks and ground up nuts, right? So those are all pretty easy things. I've included the picture that you see here is from the Food Allergy Canada Eat Early, Eat Often, and the HealthLink BC one has specific instructions about how to do this as well. So this is taking like nut or seed butters, adding milk to dilute it down for the really young infants. I don't need to do that for like older kids, obviously. Mixing it in with like breast milk or cereals or pureed stuff. I really love, so the ground nuts, right? So like walnuts, you can crush them up, you can mix them in with pouches or applesauce. I do think the one thing that we use a lot of is the nut milks, because again, like, especially if you have kids as they get a bit older, they get a bit picky, they don't want something as new, so they don't trust it. So in those sorts of contexts, we can say, well, why don't we put a little bit of like almond milk in your pancakes, right? You're never gonna know. So we can mix a lot of these things into smoothies. So we can get creative about how we do this. I think cost efficacy is a really big thing to keep in mind. I've included a picture. So I use this Elmhurst, that one's an almond milk, but I use all of the Elmhurst ones in the office quite a bit. They're like $7 to $8 a container. So they can be frozen and then like use like, you can get your money's worth out of them that way, but they can be expensive. So the most cost-effective way to do this is actually just getting mixed nuts and grinding them up. And those will actually keep for a year in the freezer. And as far as, so the next thing is how much. So what's really important, it's not about volume. Like you don't have to eat a lot of food to prevent a food allergy. You just need to eat a little bit and eat it regularly, right? So it's not about eating a lot, it's about eating a little. And it's the frequency of ingestion that we care about. So my favorite, and actually there was a study in the UK where they looked at, because we're giving this advice, like everyone eat all of the foods, but sometimes people are like, well, I don't eat Brazil nuts. Like, how am I supposed to introduce a Brazil nut? That's really annoying. So they actually studied this and they found that people who got mixed nuts, they ground them up and then just added them to stuff. Those were the people who were much more likely to actually be consistent with the regular exposure, which is the key part of this. And then from a cost standpoint, that's also the best. You grind them up, they will stay in your freezer for a year. They do not go bad. Definitely the best option. As I mentioned, so the frequency of ingestion is the most important thing. You're going to read so in the different handouts and resources that are available, there's different initial recommendations about volume. So if you look at the Food Allergy Canada handout, it talks about preparing like 2 teaspoons of the butter. The HealthLink BC handout talks about mixing up a tablespoon with the water. And you're like, well, what should I give? And then I've put a screenshot there of my handout, which actually suggests trying a little bit, waiting, and then on the first exposure going for like 1/8 to 1/4 of a teaspoon, which is like obviously quite a bit smaller. And my own, I think overall for most kids, like we just said, the rate of a reaction is going to be like 2% in the population. So for 98% of the children, doesn't matter. You could eat as much as you wanted and it would be unexciting and very fine. My own recommendations for the smaller volumes just stem from the fact that I'm often seeing kids who have one or more already diagnosed food allergies, and so their risk is ever so slightly higher. It's still not that high. They still have a better than 90% chance of like tolerating everything else, but because their risk is a little bit higher, my own preference is to start small. And then if we do see a reaction, it's much less exciting than if I were to give them a tablespoon, for example. So my own personal preference is starting low, going slow, and then in that way we'll still identify problems if they happen, which is not super likely, but when we see them, they'll be less exciting if we're going with a small amount. And as far as like ongoing exposures, right, if you're doing this with a 5 or 6 month old, that's probably all they need, right? Like this isn't for calories, this is for allergy prevention, for like interest, like enjoyment of food. So small bits are a-okay. In a lot of the like recommendations about how to introduce things, you'll see like every 5 days introduce a new food, or every 3 days. But I just gave you a list that looked like this, plus all of the broken down tree nuts. And so then you say, well, how am I going to, it's going to take me a year to try all of these things. So really one food at a time. And honestly, you don't even necessarily have to do that. Not overthinking it is, I think, a good plan. And in our handouts, and if you look at the CPS statement and the Canadian Pediatric Society statement, it'll say like 1 day between new foods. I will say, so long as you've got a good like 4 or 5 hours, you're fine. You're not going to be mixing anything up. And in the clinic, when I'm doing multiple food introductions, I'll do a whole bunch in the course of a morning. But generally, advice for parents would be 1 food at a time. I'd give a day between new foods, and then once they're introduced, make sure they're in the diet regularly. I always try, like when I'm telling parents what to do, like we give them a list with suggested forms of the food. You really want to make this easy for people, because if it's not easy, they won't do it. So giving them all of those options about the, grinding things up, or the milks, or the butters, or finding, like understanding places where you live that might sell some of these things, or places online that you could tell people about, is going to make people more likely to do this. In terms of location, so like I said, so this is very safe. So everyone should be doing this at home independently. Like there's no reason for anything else. There are some families where the level of anxiety is particularly high, and that might be related to a family history of food allergy. Lots of different reasons for that. So if people are particularly fearful, and so the question I pose to people is like, so I'm telling you to do this. Like just ask them, like, are you going to do it? And if they say no, or if they say, well, I might drive to the hospital parking lot, you say, oh, okay. So these are people who might need a little bit of additional support. And ideally, that's something like, if you can offer that in your office, have them come, hang out, eat a snack, sit for half an hour. And if everything is okay, then they can go home. It's a fairly simple thing to do for someone, not a lot of effort. And again, the rate of reactions are very low. So that is a really nice thing. If you can support someone who is highly anxious in trying to get that food into the diet, that's fantastic. I routinely do this in my practice, right? So if I've got someone who's already got 1 or more food allergies, step 1 is like, we got to make sure we try all of the other foods. So I give them a checklist, and we either do it at home, or I give them the option of being at home plus having an extra set of eyeballs with like myself, or one of the nurses that works with us, or we bring them in to the clinic and we have a picnic. So we'll do any of those things with the goal of trying to get the foods into the diet as soon as we can and have them being eaten regularly. This is just so for reference, and I'm happy to send this out as well, although this is like, again, very similar to the Food Allergy Canada one, but this is I give people a checklist. So I go through their history and figure out like which of these things have they or have they not tried. And then I send them a list and I say, okay, here's your to-do list. We're going to try and get through these things along with the set of instructions like we talked about, sort of how to introduce. So a little bit, wait a little bit more, give a day between each foods. And then we talk about signs and symptoms of things to watch out for. So I guess the next piece is now you've said, okay, I've identified my patient who's at increased risk of food allergy. They have eczema, or maybe like mom has eczema or dad's got seasonal allergies. So I've told them, okay, try all of these foods, start them early, 4 to 6 months, and then eat them regularly. And then we said it wasn't very many, but a small percentage of these people are going to have allergies to foods. So we need to know who are those people, and then who needs to come and see myself or one of my colleagues. And so one thing I just want to point out are things that are not an allergy. And I saw 3 of these cases today, which is what we call perioral erythema, or just like these like impressive red facial rashes that occur predominantly beard distribution. So they can extend to the cheeks and the chin and all the way down to the upper torso, but they're primarily localized to sites of contact with the food. And even if the parents are like, oh, it didn't touch there, if it's in this area and they're little, it touched there, for sure it did. So these areas, if we have red rashes, and sometimes that can even include small hives, but really we try and give you a bit of a pass in areas that actually came into contact with the food, because particularly if you have one of these underlying, like if you've got dry skin, eczema, one of these underlying sort of sensitive skin types, we know you're going to get rashes where the food touches. And there are some really common culprits, and that's a lot of our fresh fruits and vegetables, particularly citrus, tomato-based, anything vinegar-based, so think like ranch dressing, like ketchup, soy sauce. I'm trying to remember what this kiddo's, oh, this was a pickle. So pickles, anything. So it's like vinegar-based stuff, but it's super common. It's going to be in this area, and there should be no other associated symptoms. So it's just that. So this area, we give you a bit of a pass. We say, oh, all right, there wasn't anything not related to sites of contact. There were no other symptoms. It's okay to go ahead, small amount again, try again. Things that you can do to try and make this less bothersome. You can put on things like Vaseline or lanolin before you eat, and it will minimize the appearance. It will not make it go away, but it will make it less impressive. So generally, I tell parents like that's an option. It makes the parents feel better. The kid typically is not bothered and doesn't really notice these to begin with. So usually, because I think applying barriers before you eat every time is a lot of work, I'll tell people that they can if they want, but otherwise just go ahead, have the food, and just like don't do it right before picture day. I will say, if you're ever sort of wondering like, is this an allergy or is this not an allergy? You can always refer parents. So this is a mobile-enabled website that is like a tool to try and help people determine if the symptoms that they're having might be related to actual food allergy. So Allergy Check. The symptoms that we actually do need to be worried about, and when I'm talking to parents about food introduction, I run them through. So what are the things that would make me worried? So I just said that like redness around the mouth or like rashes where the food touches, I'm not particularly worried about. If you see that and it's where the food touched, we're going to ignore it. We're going to try again. But we do want them to keep their eyes peeled for stuff that should make them stop the food, right? So when we're trying a new food, if we develop rashes, like particularly hives, and so those are the ones that are sort of white raised, white on top, red around, itchy, and they can be all kinds of shapes and sizes. And in particular, we're looking for rashes like this that are unrelated to sites of contact with the food. So if you eat the food and you get hives where the food didn't touch, we say, that's a problem. No more of that food. Hang tight. We're going to refer you somewhere and come up with a plan so we can deal with this. Other symptoms that can be a bit more concerning. So if we eat a new food and then all of a sudden we get like big swelling, and really, face swelling can be very impressive. The only thing that's really dangerous actually is going to be tongue swelling, which is not actually nearly as common. Or if we eat the food and we have vomiting, if we are having breathing difficulties, or if there are signs of low blood pressure. And in an infant, what that looks like is sort of this, we turn extra pale or kind of like gray color, and then we become a bit floppy and harder to wake up and not as responsive. So really the things that we're worried about are breathing problems, belly problems, and blood pressure problems. So if parents see any of these things, then that is a reason to immediately seek medical attention. So if they already had an epinephrine auto-injector for another allergy, we would tell them to use that. And if they didn't, we would just say, okay, call 911 or head into the nearest healthcare provider for assessment. So again, if they just have some hives at sites of contact, they don't necessarily have to go anywhere. You don't even really need to treat that. Those will go away by themselves. typically within like 30 minutes to a couple of hours. Often they're gone before any medicines will kick in. So typically I do not recommend that parents give antihistamines, just say like watch until they go away. And then they would stop the food. But if they see anything other than just a few hives, particularly any breathing problems, any belly problems, or any blood pressure problems, then that would be a reason they should see someone straight away. So as I mentioned, so if things are just mild, they don't necessarily need to do anything, but they should stop the food. They should take pictures of any reactions so that that's helpful for whoever's reviewing it with them later. Anything more severe, they should seek medical attention. And one thing I just want to really draw some attention to is often when I see people, they might have had a reaction to something, but then they stopped giving every other allergen. They were like, oh, nope, we had one, we're stopping everything. And I guess I totally understand if people are nervous to try things, but the wait that's involved, so the subsequent delay, so if we tell them to stop introducing the foods and then it's like a few months before they see someone, we've now increased our risk of food allergy for whichever foods we hadn't yet tried. So if at all possible, to facilitate trying to help those families getting those remaining allergenic foods into the diet, because that's the number one thing all of us are going to tell them to do when we first meet them anyways, right? So I'm going to hear them and be like, yeah, sounds like an allergy. Okay, step one, what else haven't we tried? Here's your checklist, right? So that's what we're going to tell them. Let's see here. So reasons why someone should see an allergist. So if someone, particularly our preschool aged kids, if we've had clear IgE mediated symptoms, right? So our hives, swelling, problems breathing, vomiting, fainting kind of stuff, symptoms after eating a food, we want to be referring really urgently, right? So most of us are going to see our infants really quickly because we know that the delay increases the risk of food allergies. So we try and see those kids ASAP because also the earlier we see them, the sooner we can get them started on treatment. And we know that our treatment works better the younger we start. So most of us try and triage those very quickly. While patients are waiting to be seen, so things that we can do is if they've had really convincing symptoms, we say, okay, avoid that particular food, give them an epinephrine auto-injector. So there's the two kinds in like the infant age group. You've got either the EpiPen or the Allerject. Give them an anaphylaxis emergency plan, and those are easily available on the Food Allergy Canada website. We encourage introduction of the other foods that they haven't yet tried because that does two things. So number one, it reduces the risk of developing another food allergy to any foods that they haven't yet eaten. And number two, it also helps, like if they identify any other problems, then we'll treat those at the same time as their other problem. And then the last thing we should do is we should make sure their skin is in tip-top shape, right? So things like cutting out the soap, lots and lots of moisturizer, medicated topicals if we need them. We're trying to get that skin as flat and smooth as we can. So then the treatment. So say we've identified someone who has a reaction with the food that we've just tried, then we're going to send them off to the allergist, and we're going to consider, particularly in in kids who are less than 5 or 6 years of age, something called oral immunotherapy. And I think probably most people are familiar with immunotherapy. It's something you might think of like allergy shots that we do to our environmental allergies. Some people do treatment for our environmental allergies with these little tablets that go under the tongue, like sublingual immunotherapy. And now for food allergy, we have oral immunotherapy, right, where we eat the food. So immunotherapy in general, like just the word, means we're trying to induce temporary as well as long-term non-reactivity to something through the process of regular exposure. So this is really a treatment that's for IgE-mediated allergy specifically. And there's sort of two pieces to it. So the first piece is desensitization. So this is where your immune system has labeled a thing wrong. You've made an IgE antibody to the peanut, for example. Your immune system thinks it's a parasite. And what we're doing is we're giving you little bits of it so that you stop reacting to it when you see it. We start at a tiny amount. We start at a dose that's too small to cause any significant symptoms, and we go up a little bit higher, and then we keep giving it to you. And if we do that and you're doing it every day, you're not reacting to it. That's desensitization. So you're not reacting to it. But if we stopped giving it to you and then we gave it to you, you would react, right? Like we didn't actually fix the allergy. We just desensitized you, right? So immunotherapy does, first thing, desensitization. And desensitization actually can happen really quickly. And maybe some of you guys have seen like drug desensitizations, which we might do over a period of a few hours or days, right? So we can do desensitization fairly quickly. But this is something that requires, like, we have to keep giving it daily. And if you stop, like, we didn't actually fix the problem. Your immune system still thinks that the peanut is a parasite. What we're actually more interested in doing, like, desensitization is great, right? If you're desensitized to peanut, then you can go out to the Thai restaurant and not worry, right? Like, you can eat the Make and Contain, you can go to the bulk bins, like all of these things, we've taken the risk out of them, right? So desensitization is awesome. But really what we're all wanting, right, is not having the allergy anymore. Like, that's what we really want. And so that's the induction of tolerance. And so tolerance is this state of long-term, so not temporary, but long-term non-reactivity to an allergen that is independent of ongoing exposure, meaning, like, you don't have to keep having it every day like a medicine for you to not react to it, right? So really, so immunotherapy, we have those two goals. First, we desensitize you. And then if we keep doing it for a long period of time, and that might be years, many years for some people, then maybe we can get to tolerance, which is where we kind of fix that immune system labeling error. So this is just, this graph kind of talks about sort of the early effects. So in immunotherapy, we can desensitize you within like hours to weeks. Like, we can get there so quick where you're no longer reacting to something. But the late effects, which is actually where you see IgE go down, like that allergy antibody, which you normally make to fight a parasite. So that which is starts out being very high over a period of years in immunotherapy. And this graph is talking about subcutaneous immunotherapy for environmental allergies. Principle is the same, but it takes a long period of time to kind of turn off that labeling error. And what you actually see is so you see the IgE, so the allergy antibody, go down. And you actually see your memory antibody, IgG, go up. And this is of relevance to any of you who've ever seen those like tests ordered by, you know, sometimes that people can get through the pharmacy or through naturopaths looking at like food intolerance tests. They measure IgG antibodies. And for an allergist, I'm like, IgG, yes, you're not allergic. So IgG is actually a great marker of tolerance. Anyhow, so the point being, immunotherapy, we desensitize you. And then if we do it long enough, we can like fix the labeling error and cause tolerance. So oral immunotherapy, this has actually really just been in the works for the last like 15, 20 years and really more widely available probably only in the last 5 to 10. It's most commonly done with peanuts, although there's lots of us who will do, like, we'll do it for anything. The principle applies to anything. The basic idea, and remember what we said before about like the route of exposure matters. So we want to take advantage of those little cells in the gut that send out the little chill out messages, right? So we want to be eating the food and exposing ourselves to it through the gut so that we can fix that labeling error. We want to train our immune system that the food is a food. And so immunotherapy, as I mentioned, so it does two things. So first, with desensitization, it reduces the risk associated with accidental exposures, right? So if your peanut allergic child is eating 2 peanuts a day and then their friend at daycare gives them their peanut-filled cookie, nothing bad is going to happen, right? We're going to be fine. So that it reduces those accidental exposure risks. And then if we start it young enough, and particularly in this like less than 5-year age category, it looks like we can essentially turn the allergy off relatively easily. So the younger we start this, the easier it is. We're just about to publish our, so I'm part of a group of allergists across Canada who are doing a lot of oral immunotherapy and looking at our sort of safety and efficacy data. We're about to publish our infant data. So looking at our kids where we started them at less than 12 months of age, and it is awesome. So way safer, way easier, shorter duration of therapy, really effective at changing the natural history. So essentially preventing them from keeping the food allergy long-term, which is really our goal. So in terms of what oral immunotherapy looks like, so generally there's an initial assessment by the allergist, and number one, what we're wanting to do is confirm food allergy. So we want to see that there's a history of reaction on ingestion unrelated to contact, plus evidence that the person has made an IgE antibody to the food. And in some cases, if we're not sure, so we will take a really good history, we're going to do our testing, and we may decide to do a food challenge to confirm that diagnosis. Once we have, and we decide that food immunotherapy is an option and that's something that the family is interested in doing, then we arrange to start. We kind of pick a starting dose based on that story and our numbers, and we're trying to pick a dose that's like where we might get a few symptoms, but like not any exciting symptoms. So the first dose, we're trying to find that sweet spot where we might just get a few hives and nothing else. And then once we've started, so we do the first dose is often done in office or under observation. And then we watch them, make sure nothing happens. And then they go home and they take that dose every day for, depending, 2 to 4 weeks. And then we'll see them again for dose increases. And depending on the person's risk profile, the dose increases might be done either in person, in the office, or they might be done at home with telehealth support. And again, we sort of rinse and repeat every 2 to 4 weeks. We go up on the dose and then stay at that dose for a while until we get up to a maintenance dose. And for an example, it's not a huge amount of the food. For peanut, it's like 2 peanuts. So that's like 2 peanut M&Ms or 4 Reese's Pieces or 4 Bomba snacks, right? So we're always trying to do this in forms of the food that the child will eat. Maintenance dosing might be for, honestly, for most of our preschoolers, it's a year. Occasionally it's a few years. And then for our older kids and adults, we tell them to expect that it may be lifelong. In terms of our testing, so for all of our kids, we get them up to maintenance, and then the typical process is at the year mark, we'll repeat our testing, and then we'll do 2 sets of challenges to assess efficacy of the treatment. So the first challenge, so they're still eating, they're taking their 2 peanuts every day, and then they come back to me at the clinic, and instead of giving them 2 peanuts, I give them like 20 peanuts. So we have, instead of just a little bit, we want to see, like, are you desensitized? Like, you're only eating a small bit, but are you protected against a much larger amount? And the data on this is great. So with our first like 300 preschoolers, and this is held up now that we've got like 700-800 kids in this so far, where we have like better than 80% of them who can tolerate like essentially a tablespoon of peanut butter without any symptoms at the end of a year of treatment, which is really impressive. And then the next question is tolerance, right? So have we like fixed the allergy? Can we get rid of the EpiPen? And that's really sort of the more exciting question. So the kids, they're taking their dose every day for a year. They come back. We do this challenge to like a huge amount. If they pass that challenge, then I tell them like, we're no peanut for a month. Like, don't eat any for a month. And then they come back, and then I give them a big amount again, because now I'm asking the question, what if you're not eating it every day like in medicine? Can you still tolerate a really large amount of the protein? And that's called sort of the sustained unresponsiveness at 1 month challenge. And so if you pass this challenge, that tells me that you're able to tolerate it after a month of not eating it, a big amount. That is sort of our proxy marker for saying that the allergy has more or less resolved. And so at that point, if they pass that second challenge, I get to say like, okay, you don't need the EpiPen anymore. You don't need to say that you're allergic to the peanut. And a good 80% of my patients definitely trend. So the caveat here is that my patients are very young, like a lot of the people I'm starting at sort of the just around the 12-month age mark. So our data is really great with a lot of people, like better than 80% of our kids passing their 1 month sustained unresponsiveness challenges after just a year. Lower rates of success in people who start when they're older. In terms of safety, so very safe. I would say much like if you've seen people with subcutaneous immunotherapy where we might get like local reactions or hot, like reactions are common. We are giving you something that you're allergic to, so we tell parents to expect reactions. Reactions are also not a bad thing. What's super fun in immunotherapy is that we do the dose and maybe we have a few symptoms, maybe we get a stuffy nose or we get a few hives, and after a few days at that dose, that goes away. So you can really watch the body becoming used to the dose of the food, and then when we come back, we go up, we see the same thing. So mild reactions like a few hives, a bit of flushing, a stuffy nose, a couple of sneezes, bit of belly pain, those are very common with the doses. We tell people to expect them. But significant reactions, so particularly anything requiring epinephrine, so that would be breathing problems, belly problems, blood pressure problems, very rare. So 4% of kids needed epinephrine, and that was much reduced to down to like 1% or less in the younger age group. In terms of like what this looks like in some of our daily dosing, so for some people we use capsules, other people we're using milks, and we usually mix those into our foods and feed them. And I really have to say this is like the most fun thing that I do in my practice. In particular, when people get to maintenance and we get to say like, oh, you don't have to worry about the may contain labels, you can go and eat at a restaurant. Can be really liberating for families. One thing in terms of being able to access oral immunotherapy, we want to recognize that this is offered by most, but not all pediatric allergists yet at this stage, and that'll improve over time. For preschool age children, we want to make sure we're referring like quickly as soon as we notice that there is a problem to someone who's offering oral immunotherapy. With Zanetta's help, so we're working, myself and Dr. Bahar Tarabi are working to have outreach clinics available, and we want to speak and hear from you about how we can best support your patients in accessing this locally. So what can we do so that patients even in more remote areas can feel supported and able to access this treatment. So I wondered, and just points for discussion, and now sort of I'm done and can take any kind of questions, but things that I wanted to think about if people have suggestions for this, or what are some of the barriers. Like I recognize, when we're living outside of larger cities, so, the Brazil nuts are harder to find. and some of those snack foods might be more difficult, or potentially these are not things that are routinely in our diet. Perhaps we're not as familiar with food allergy, or maybe we're not always presenting to healthcare attention for it. So what are the things in your patient populations that you've identified as potential barriers for this, and can we brainstorm any ways, what can we do to try and reduce our rates of food allergy, and then to identify early and treat if we see them?
Perfect. Gosh, thank you, Vicki. I don't know about everybody else, but this is so exciting because so much of what we do has no real significance sometimes, and this is something we can definitely change. So I have some questions in line if people want to send them to me. So the first is, what is the likelihood, Vicki, that immunotherapy would work in an older patient with an oral allergy syndrome?
Oh, that's a great question. Yeah. So I guess so oral allergy syndrome, for those that aren't familiar with it, actually maybe, I think I shared PowerPoint. Okay. So oral allergy syndrome is essentially, the problem is not an allergy to the food. The problem is that we're allergic to a pollen. And there's some proteins in fresh fruits and vegetables that to your immune system, not to your eyeballs, obviously, look like the pollen. So for example, if you're allergic to birch pollen, you might get itching and tingling and swelling when you're eating fresh cherries or apples or pears or carrots or celery, or I don't know, a lot of delicious things. Anyhow, so typically the symptoms, and the way to distinguish between like a food allergy to a heat stable protein within a food versus a problem where you're actually allergic to the pollen and the food isn't really the underlying problem. So usually food pollen syndrome symptoms come on at an older age. So not necessarily when you're little and you might have many years of enjoying the food before the symptoms develop. And then the other way that you can try and tell the difference is if you can tolerate the foods in heated or processed form. So say the carrots cause like mad itching when they're raw, but if you heat them, you're like, okay, like it's not as bad, or I can tolerate it. So that's how you can tell, because the proteins that are similar between the fresh fruits and vegetables and the pollens are really wimpy. So they're highly susceptible to heat and acid. So heating it up and processing the food will make the symptom go away. And then that's also why you're not really at risk of like anaphylaxis as much, right? Because as soon as it gets broken down by the acid in your stomach, it's not there anymore to be a problem, and it shouldn't really cause that as an issue. So the question of like, can you treat it with immunotherapy is a little bit more complicated, because the underlying problem again isn't the food, right? So oral immunotherapy to the food is probably not the best way to do that. So instead, what you actually want to do is treat the pollen allergy. And there's mixed data on this. So subcutaneous immunotherapy, like allergy shots for pollen allergies, they don't have 100% success rate in treating oral allergy syndrome. They're really good at treating like the conjunctivitis and the sneezing and the nose symptoms. They're less awesome at getting rid of the mouth symptoms. But there is now, as of last year, we have the sublingual tablets out for birch pollen. So particularly for oral allergy syndrome, there's like the birch pollen cross-reactive foods, and then there's like the grass pollen cross-reactive foods. So now we have tablets for birch pollen, for grass pollen, and for ragweed, which kind of cover the main sets of like food pollen syndrome issues. And they haven't done the study for the grass and the ragweed, but the study looking at birch pollen actually shows that the tablets are very helpful at reducing the oral allergy syndrome symptoms while you're on them. There's not really great long-term data yet. But if you did achieve like proper induction of tolerance where you no longer made that IgE antibody, whatever method of immunotherapy you use, then you really should fix that problem. And sometimes it goes away by itself with time, and sometimes it also gets worse. So, but if you have access to those little tablets that go under the tongue, and if your problem is the birch pollen one, then there's good evidence for that.
Vicky, I have a couple questions, if that's okay.
Yeah.
Okay. So question number one is with respect to the test you do after oral immunotherapy at a month to understand better whether or not you have sustained tolerance. After that, when you get rid of the EpiPen, is this all based on the assumption that they will continue to eat and expose themselves to peanuts?
Yes, and that is, thank you. That's such a great point, and I should have said that. So you're quite right. So if they say they pass their 1 month sustained unresponsiveness challenge and then they go home and never eat peanut again for a year, could they redevelop a peanut allergy? Yes, absolutely. In fact, you know, unless their skin tests and their blood tests are totally negative, then the likelihood is quite high that if they stopped eating it completely for the next year, we would have a problem again. So yeah, so once someone passes their sustained unresponsiveness challenge, then we encourage them to keep peanut in the diet regularly a few times each week. And then the question comes up like, wow, man, like how long do I have to remember to do this for? Like it's great if everyone loves a peanut butter sandwich, but like not every household is like that. So, you know, what do we do? And there's not really strong data on that yet, particularly in the context of oral immunotherapy, but we do have data from that LEAP. So that one study from 2015 that did the early introduction versus the withholding peanut. So that particular trial, they published another one a couple years after that. So all of these kids, so they took like, you know, the 500 or 600 kids that had been eating peanut most days of the week since they were 4 to 11 months of age. Now they were 5, they didn't have a peanut allergy. So of that group, 50% of them, they told them, don't eat peanut for the next year. And then the other 50%, they said, go ahead, eat peanut. And at the end of that year, so these are people who'd eaten peanut all the time until they were 5. And then half of them didn't eat peanut for a year. Most of them were okay. Not all, but like most of them. So that suggests to us that probably if you've eaten it regularly and you don't have a problem, by the time you hit sort of 5 or 6 or school age, it matters less if there's a bit of variability in terms of the frequency of exposure. We haven't done a study to say like, well, what if I ate it 2 times a week until I was 3.5? Like what would happen then? I don't know. And, you know, honestly, some kids, it matters more than others, right? Like I have some kids who, you know, we'll go through, like I'll see them, we'll do all this early introduction. We say, we don't have a food allergy. And then, you know, say they like miss a few months. Some kids are fine, others are not. Right. And so we right now don't have a good way of predicting who matters, because I've seen kids even with a month where we went only a month and all of a sudden, bam, like they were tolerating it and now they're not. So in general, I say like you've shown, like your immune system has shown us that we might make a labeling error. Like we're, you know, so we should be mindful, and the best way to prevent that is to try and ensure that it doesn't have to be in big amounts, right? It just needs to be in the diet a little bit regularly to try and promote tolerance.
Okay. I have some really good questions in the chat here from Paul Warbeck and Emily Lyle. There was a lot of work done in the late 90s about the passage of intact proteins like cow's milk albumin into breast milk. So like maybe 30 years out of date. Is there any new relevant work on this that is relevant to the emergence of childhood allergy?
Yeah, so that's a great question, and also like one that's hotly debated, along with like maternal ingestion of allergens and like does it increase our risk or decrease our risk, or like what's the story? And I think overall, like I guess just from an allergy prevention standpoint, I would say that passage through the breast milk largely doesn't count. So it is, nothing in life is impossible. So it's not impossible, but it is like extremely unlikely that you would see manifestations of IgE mediated allergy to a protein that is excreted through the breast milk. And overall, seeing the broken down proteins not considered protective against IgE mediated allergy. It's really enteral exposure into the child's gut directly that is protective. I think one of the things that it makes like this data hard to interpret, because there's huge studies on this, and like half of them are like, it's helpful, it's harmful. Like it's really, there's no difference. It's really not clear. And I think one thing that we're really missing in trying to interpret this data is the fact that if parents are eating the food in the house and a breastfed child that is not yet eating a solid who has eczema is there, then the food is getting on the skin. Like if you eat peanut in your house, then doesn't matter how clean an eater you are, we can find that peanut protein in your dust. We can find it in your bed sheets. Like the peanut protein is around in the environment, right? So if something is eaten in your household, it's actually interesting because I think a lot of parents are like, I'm protecting the kid by not giving them the food. And I'm like, oh, no, they're seeing the food, but they're just seeing it through the skin. Like the food is there. So I think, yeah, I guess like largely I would say my own personal take on all of the data is like that people should eat whatever they want to eat. And I wouldn't consider it like protective or harmful. And what we really need to sort of keep in mind is like, if we've got that eczema, managing the skin barrier as much as we can, and then making sure as soon as the child is able, getting the food in the diet. It's a great question. And there is much debate, and there's been many studies, including from our own like Canadian, like the child study data set looking at this, but yeah, largely controversial.
So awesome. And then I'm just checking the chat again. Nothing's come up. My one question is just on a practical standpoint. So let's say we're in a remote community, and I can think of two scenarios. So scenario number one, let's say 9-month-old eats, let's see, peanut butter, goes into the emergency room with not just contact, but hives on his feet, a little bit of wheeze, within about 15 minutes of taking the food. One of like a red herring might be it's the first time he's ever had peanut butter. My message that I'm getting from you is to say, believe it's probably an anaphylactic allergy based on your history and what you're seeing to peanuts. Give them the epi and the right treatment in the emergency room. And then make sure that they have follow-up and hear the message that, yes, get your EpiPen, but go to your family doctor and figure out the route that's best for you in your community to get to someone who might be able to consider OIT if it's safe.
That's exactly right. Yeah. So certainly like having a reaction on the first exposure, remember that like often like our initial exposures have actually been through the skin. So it's perfectly like it's I mean, not necessarily typical one way or the other, whether you like have 1 or 2 exposures first, and like remember volume matters, right? So if someone's maybe had something a couple times at a small volume and then they eat it at a bigger volume, yeah, you might see reactions, but it's not uncommon on the first exposure to see problems. And that's just because of the sensitization or the development of IgE antibodies has happened because we first met the protein through the skin and not through the gut. So if we have a reaction, especially so exactly as you mentioned, so hives unrelated to sites of contact, other symptoms, so wheeze count, so that we meet criteria for anaphylaxis, epinephrine is our management. And then exactly as you said, so we're going to avoid peanut, we're going to give them the EpiPen, we're going to refer them to the Food Allergy Canada website. There's other great resources like allergyaware.ca has a wonderful like training module on when and how to use the epinephrine autoinjector. Gives people a little certificate, so like grandparents who are looking after the kids who are like responsible for a lot of accidental exposures, they can go through and like, you know, do this training so that the parents are reassured that they're all on the same page. So you want to make sure people are prepared, and then you want to encourage them to try those other common allergy causing foods. And then, and then try and get them seen as soon as possible because, you know, if they're infants, they're great candidates. Like you've identified the problem at an age where we can actually do something about it, which is key.
Great. Okay, that's so awesome. Paul Warbeck has another really good question. I understood your comments about how antihistamines may not be required for minor urticaria responses. For more widespread and persistent hives, did I miss your comment on diphenhydramine versus cetirizine?
Yes. Okay. So it's a great one. So allergists, we all have this, like, allergists just, we hate Benadryl. So this is, it's a great point. Yeah. So in general, I will say, like, so I do a lot of like food challenges, obviously, in the clinic, and I do a lot of food introductions. We see a lot of hives, and I use antihistamines almost never. That's simply because, like, most cutaneous reactions fix themselves, right? Like, to the tune of like 30 minutes to a couple of hours. And it depends a bit on how bothered the child is by it. So if someone's had sort of more widespread hives, they've gone on for like sort of 30 minutes and you're really not seeing anything else, then treating with an antihistamine would be appropriate. Always the non-drowsy antihistamine, regardless of the age. And I know some of them say, like, not for less than 2 years, they're not indicated. All antihistamines that exist are safer than Benadryl. so it doesn't matter which one you use, whether that's like loratadine, like Claritin does loratadine aereus, cetirizine, Reactine, or there's like rupatadine or Rupall now. So any of the non-drowsy ones are more appropriate. And there's like a good rationale behind this. So, like, a short duration of action, right? So diphenhydramine is like 4 to 6 hours. Also loads of side effects like dry eyes, dry mouth. If you're using it all the time, like problems peeing, problems pooping. Long-term use now, there's data, so like saying that you could get like higher incidence of dementia. Like, my favorite study was, like, they took people and they gave them either diphenhydramine, or they gave them alcohol, or they were sleep deprived, and then they made them do a driving test. The people that did the worst were the people on Benadryl. So
nice.
Those people who are like, no, it doesn't make me sleepy. You know what? Your reflexes are still impaired. So, like, we should just pick anything else. Honestly, the only reason Benadryl is still here is because it's the only IV antihistamine that we have. Right, we do not have another option in North America at the moment for IV formulation, and that's why we're not for the moment going to get it out of emergency, and it's still going to be very popular, and the marketing is great, right? Like, everyone wants their Benadryl. Like, even though we know that the time to onset is like the same as the other ones, and like cetirizine and diphenhydramine have like identical time to onset. I have so many of like my adult patients who are like, only Benadryl works, but
yeah, and it works like a hot dam on a 2-year-old on a plane. So, from the pediatrician. Okay, so
say, like, just in the context of food allergy, though, like, the sedation is a really big piece here. So especially in young kids, it's difficult to get a blood pressure, right? Like, even if you've got all of the right equipment, getting a blood pressure in a small child is really tough. And so our indicator for blood pressure is your level of consciousness. If I just dose you with a bunch of Benadryl, you're going to be sleepy, you're going to be floppy, you're not going to respond to me, and I don't know if that's your blood pressure or is that the Benadryl. And so particularly in the context of food allergy, we really should not be using Benadryl because it takes away one really important vital sign from us. So I would just say, in the context of food allergy reactions in general, like, avoid antihistamines when you can. Honestly, like I said, a lot of the hives go away quickly. Anything that is not hives, like, antihistamines are not your medicine. Like, it's epinephrine. Really, all antihistamines do is they reduce swelling and itch. They do not fix breathing problems. They do not fix blood pressure problems, right? So the things that are dangerous, things that can kill you, antihistamines do not touch. So really, we should be watching, making sure there's no other signs or symptoms. If there's anything else, they go into hospital and they get epinephrine. If it's just cutaneous stuff, antihistamines are fine, but use one of the non-drowsy options. Definitely much safer.
Perfect. Another great question in the chat from Heather Siemens is, what do you do if they have widespread hives, like an 8-month-old? Initial mild wheeze, but not sure what they were exposed to. Don't think there were any new exposures. What about if the hives are persistent?
Okay, so that's a great question. The latter bit about the persistent, it makes your life so much easier, in the sense that if someone is like, oh, I've got hives, and if the hives have gone on longer than like 24 to 48 hours, then you get to be like, whew, like, not an allergy. so I guess that's the timing is the key distinction. So allergy hives versus not allergy hives. Like, I always like to tell patients, like, allergies are really easy. Like, you're exposed to the thing, whether that's like you eat it or it stings you or whatever. you're exposed, the problem happens, and then it goes away. Like it doesn't kick around longer than 24 hours. I know sometimes like bad swelling can take a little bit longer to resolve, but like hives, they go away with an allergy and they do not come back unless you're exposed to the thing again. So as soon as you've got someone who's had these hives and they're going to waffle along and we're 24, 48 hours or longer, then you can safely say like, whew, not an allergy. Those are the non-allergy hives. And to be honest, like non-allergic hives are much more common than allergic hives, right? So like typically in kids, that's either like concurrent with a viral illness, even if there's no other symptoms, that can be your only symptom of a viral illness. Post-viral, that can happen like anywhere from like, 4 to 8 weeks after we saw a viral illness. And it's sort of like, it's a couple of reasons why that happens. And one is that inflammation in general lowers our threshold for mast cell degranulation. So having a fever or like mounting an inflammatory response makes our mast cells more likely to go off. So when we're acutely unwell, our mast cells will puke up histamine and we might get hives or swelling. And then the ones that happen sort of after and then often go on for a little bit longer are considered more of an autoimmune phenomenon. So in the process of trying to fight some kind of infectious agent, we've generated an antibody that kind of tickles our mast cells and makes them more likely to go off. And that's usually the underlying cause of what we call chronic hives, where you've had sort of hives most days that go on longer than sort of 6 weeks. And I guess the sort of question you said, what was the initial thing where we said the person had hives and maybe a bit of wheeze and we're not sure? And I guess like you can get people to go through and sort of say track their potential exposures. As soon as it goes on a little bit longer, then you're like, oh, don't have to worry about it. But if it's sooner, then you just want them to track and see. If there wasn't anything obvious, then I don't necessarily recommend that people avoid anything in particular, just that they watch for it going forward. If they've had clear anaphylaxis where there was breathing problems, belly problems, blood pressure problems, even if we're not sure of the underlying cause, I will often prescribe an epinephrine auto-injector and run through sort of like the indications and technique so that they know how to use it. There are like idiopathic anaphylaxis can happen, not often in infants, but that can be a thing. So I think if you've seen anaphylaxis, it's always reasonable, particularly if they've got extended health coverage, make sure they get the epinephrine auto-injector. But if it's just hives, and especially if they waffled on for a while, then you can safely know that those are not an allergy.
Awesome. Next question from Tanya Peaver is, what are your thoughts on adding an H2 antagonist along with the antihistamine for treatment?
Yeah, it's a great question. Like typically, in the context of a food allergy reaction, like wouldn't typically need to. I would say the only times that I'm really doing that is if I have a bad chronic hive. These are normally adults and less likely in kids, but like a bad chronic spontaneous urticaria patient where I've maxed out I'm at quadruple dose antihistamines, right? Where I'm 40 milligrams of cetirizine. Maybe I've added on something sedating and I don't yet have approval for omalizumab.
Yeah.
So I'm struggling because this person's not sleeping and they're scratching their skin off. That's usually where I'll add it. I don't usually use it in the context of either anaphylaxis or food allergy reactions. The evidence is not great, but it's not gonna hurt. And it might help. So I think that there's low harm. There may be help, but I would say like mostly in the allergy clinic, we're like epinephrine or bust, and very rarely do we use anything else.
So awesome. Next great question from Lise Lupins. The NIAID guidelines had recommended testing for high-risk infants prior to introduction of peanut. We have seen a different recommendation in Canada. However, are we still seeing a lot of people pursuing testing prior to introduction and possibly, therefore delaying introduction?
Yeah, that's a great point. And your point about delaying introduction is the rationale for why the Canadian people, so Edmund Chan out of Children's was on that guideline, right? And so he advocated very strongly to not have that included. But, the US is a bit of a different atmosphere and obviously how they practice is quite different. So in Canada, strongly recommend against testing prior to introduction, mostly just because it's not useful. Like it's about as useful as doing like an x-ray of your left foot. Like the testing, our allergy tests, and like I'm an allergist, obviously I need my testing and I use it, but they're really bad, right? So a positive test, if you haven't eaten the food, is about as good as a coin toss, right? So it's like if you have a positive test and you haven't eaten it, it's 50-50. Whether you're allergic or not. So you're still going to need to eat it. right? If we do the test and it's positive and you haven't eaten it, I still have to do a food challenge. So I sort of, spit that, like, you're going to have to eat it regardless. And then maybe I don't have to scratch you or test you, because if you eat it and nothing happens, then we don't have to do that. So I guess, like, I suppose the question there is sort of like, what do we do in this? And I will say that a lot of people rely on UpToDate, and UpToDate is an American resource, and it cites the NIAID guidelines. And so a lot of people who are referring that might see that flow chart and then see that recommendation and try and pursue that. So I would try and, like, wherever you're seeing that, I would try and correct that if you can, you know, to the best of your ability. Say, like, that is not the recommendation in Canada, and it is very clearly not the recommendation in Canada. All of our guidelines, so the Canadian Pediatric Society statement, clearly we recommend against testing prior to introduction, namely because we know that will delay introduction, and also the testing is not, because again, it's not that great. So in terms of trying to reassure patients, like, we through Food Allergy Canada, I can try and find the link and send it out, but Alyssa Abrams did a wonderful talk targeting parents, I think, namely sort of addressing some of these points about the safety of early introduction. And that's, like, so trying to refer parents to other, like, very well established appearing resources like Food Allergy Canada. I think seeing it from good, well-standing Canadian sources will help to sort of reassure them that is not needed.
Awesome. So I'm just cognizant of the time. I have one more question here from Heather Siemens. Very good question. Is there a list of immunologists who do the oral tolerance treatments in BC? Is this something that can be done by distance if there are no visiting specialists to that community and the patient may not be able to travel?
Yeah, so this is an excellent question, and we just did our sort of recent, like, the BC Allergy Society meeting. We're tossing around, like, a discussion about you know, whether or not we could sort of put together a list. The thing is, it is changing over time. Like, more and more of our colleagues are becoming, like, they're like, oh, look, it is easy, it is safe, and then, you know, they're coming on board. So it's not static, but I'm always happy to make referrals. So if you have questions, I'm happy to be contacted, you know, to offer something. And then this is something that we're actively working on. So myself and Bahar are now starting outreach clinics to Terrace. And I mean, I've got to say, a lot of my food allergy patients on oral immunotherapy, like, I see, you know, I've got, you know, more than 10 patients who live in the Kelowna Kamloops area who don't come to clinic and who do all of their doses telehealth. I follow several patients, like, North Island, Powell River, so, like, all over. And it depends a bit on the context, right? So certain higher risk individuals, we may need to arrange in-office things. But also, like, the way I see patients in the Yukon too. So I've got people up in Whitehorse where they may have traveled to clinic for some initial assessment, but for a lot of their treatment, we can do a telehealth. And then also we can bring other practitioners in the community on board. And that would be the goal for things that are sort of higher risk, like that very first dose where we want to make sure we got the right dose to start off with. That's always nicer if that's done in a monitored setting. Makes everyone feel more comfortable, and then maybe they do the rest of their doses over telehealth. So if we have a place that's willing to offer that monitored setting and sort of be eyes and ears and there for a physical exam if it's needed, then I am, like, there are several of us, myself included, who are more than happy to try and, like, hear that story, do the assessment, get the testing done, because sometimes we don't need to do the scratch test. We can do the blood test instead and get treatment started as soon as possible for these kids in their local, like, without the need for extensive travel.
And that is so true. And Heather, just like a point, Vicki and I have been talking to Christy Chan in the Nass Valley to try to bring a really remote community some allergy support. So I think it's an evolving process led by amazing people like Vicki. Now, just before Paul's excellent question about how much you hate gravel, can I just make one comment? Can you teach me with respect to so the RAS test or the blood test? So and I see this used a lot, and I don't really know how to use it, but is my feeling right that, so let's say that 9-month-old comes in with a possible allergy, and they go, and I've told them, here's your EpiPen, avoid the peanuts, but I think you've got to go to your family doctor to find an allergist. Would it be right to say that the recommendation from Allergy Canada is to just stay away from that blood test unless discussed?
Yeah, so that's a really good question. So the thing that you brought up there is a little bit different. So that's someone who's eaten it and had a problem.
Right, right.
So that is a person where we are going to want to do testing. I think I would probably, I'm not sure that I would recommend pre-ordering it before the allergy assessment, just because with the serum IgE blood test, like once it's drawn, I have 30 days to add other stuff to it without having to poke the kid again. So I guess all I'm saying is a lot of the kids that I see, when I see them, they haven't introduced, like there's like 8 or 9, like we got a checklist to get through. And so we might uncover some other problems, maybe not, but maybe we'll uncover another problem. And I would hate for them to have a blood test done and then for us to be like, well, we're going to have to poke you again. That's kind of a bummer. So it's not to say that that would be out of place. Like if someone has had a clear IgE mediated reaction, getting a baseline testing, whether that's in the form of a skin test or in the serum IgE, is not inappropriate. And I would always do that prior to starting oral immunotherapy. But I think the reason it might be nice to leave that to whoever the treating practitioner is A, they might want to order it to other things, right? So there might be some other considerations. We were talking about oral allergy syndrome before. So in a patient who might have seasonal allergies, maybe I also want the birch pollen serum IgE. So, because I need that to interpret the peanut, or maybe there's other foods that we want to add onto it. And additionally, the timing is important. So when we're doing the serum IgE, I do that primarily. So the skin test gives us sort of like a yes or no answer, like the number, the size, kind of, we use it as a guide, but more or less it's yes or no. Do you make an IgE antibody to this thing? The serum IgE gives us a number that I can actually track over time to assess my response to therapy. So that is like, so I like having that right before I start therapy. If I have it like 6 months to a year before I start therapy, it's less useful. Like that now I'm like, oh, do I poke them again? Like, oh, I sort of want, I need one now, but like, yeah. So probably, yes, it's a right thing to do. So your thought about that, like, do they need that test? Yes, that kid who's had that reaction definitely needs that test. But if you're going to be referring them off, I would just hang tight on that and leave it.
Okay. And then the unspoken flip side of what you're saying is kid with no exposure whatsoever through the mouth that sounds like anaphylaxis. This kind of RAS test or blood test can actually be dangerous. It shouldn't be ordered without that context.
Yeah, so exactly. So if someone has not had specifically IgE mediated symptoms after eating the food, then that test it's just useless. It's not helpful. Right. I had one the other day and I felt like, this child had been having sort of chronic hives. So these are these hives that someone had, where they had been going on for several days. So they were not allergy hives. They also had a little bit of eczema. So a food, the bane of our existence, the food mix got ordered, which is a terrible, it needs to go off that panel. It's like none of those things are related. Why would you ever want all of those things? But I guess like it allows people to test multiple anyhow. So this kid had this test done and he's got eczema. So he's like positive to everything, but he eats all of the things. So he is not allergic to any of the things. He eats them all. But he's got a bunch of positive tests, right? Because he's got eczema, so he's labeled a lot of stuff wrong, but he's not allergic. And when the test came back, the person who had ordered them was like, oh no, like maybe he's allergic. So they called the parents, and then he had a peanut butter sandwich with him at his daycare. And they actually ran and they took out his poor kid lost his peanut butter sandwich because of the test. But the point is, like, the test is useless. That, he had a positive test does not mean you're allergic, right? It just means your immune system is a bit confused. But if you're eating that thing and you're not having a reaction, you're not allergic to it. And similarly, if you haven't eaten it, the positive test just doesn't mean anything, right? It's, again, if it's positive, you have a 50-50 chance, like allergy versus not allergy. So, I'm trying to think, there are contexts. So if you refer someone off and they've got like several other food allergies and now they're multiple, they're like not an infant anymore, they're 5 or 6 and they've never eaten these things and they've got bad eczema, you might see someone test because the odds of them having an allergy at that point then are like a little bit higher.
Right.
So then but anyone who's ordering those tests should be prepared to offer oral food challenges to clear up whether that's an actual problem or not. So we shouldn't be ordering those tests if we're not willing to like challenge the food and make sure it's a problem.
So good. And then now Paul really wants to know, do you dislike Gravol and dimenhydrinate as much as you dislike Benadryl for kids? Just as much as he dislikes it for kids, adults, and the elderly, so mostly everyone.
I very much do, Paul.
Vicky feels you, Paul. Vicky feels you.
Great. Great.
So I'm just cognizant of the time, but love and feel very passionately about the social barriers that you have brought up, and just wondering how everybody else feels. Should we table that and maybe have a discussion, have you back at some point, possibly with an interest group?
I would love to have a discussion around that, because I know after our experience in the clinics, and just for context for the people listening, so we started, multiple people on oral immunotherapy, and we had one person continue on and then 2 people stop. And I think there were some barriers as far as travel and accessing some of the foods and, lots of different things. And I think it's good to debrief with some of those families as well to try and better understand that. But all of these people sort of lived at quite a distance. And so trying to ensure that we have like peer supports as well as like healthcare supports in the home communities to make this a reality for people, because it is life-changing. Like it's keeping a peanut allergy versus not having to deal with a peanut allergy when you're older is a big deal. So I would love to hear more, the challenges of early food introduction. So I know from people in some of our, North Island communities, they're like, I'm not going to get mixed nut. Like, where am I going to get that from? Like, what is really important? So trying to figure out like where can people in remote communities access some of these foods in a cost-effective way? How can we facilitate regular exposures to these families? For these families. So what are the things that we can do to better help ensure so that we get good prevention of food allergy and then early identification and treatment?
So awesome. So I think for everybody who's still on and people who are leaving, big picture ideas I want you to know from here is that this talk is recorded, so tell your friends. Thing number 2, Vicky will send out her resources via Jaylene, as well as her office information, because she is a great resource. And then any interest in like kind of moving this forward, increasing education for multidisciplinary teams and in remote communities, please contact myself and Vicky. And I think we both feel very passionately about this. All right, everybody, go eat a peanut butter sandwich if you can. And we will talk to all of you soon.
Thank you so much, Netta. Thank you guys for having me. This is great.